This is anxiety disorders and fear-related disorders. It's the last chapter that is left for the clinical chapters that I have to upload. And then after this, I will probably start working on the health studies. And then maybe after that, consumer. And then lastly, probably organization. So it might take some time, but you can expect some health videos before the May June exam series for 2026. So like any other clinical section, we have the three, or clinical chapter, we have the three sections of diagnostic criteria, the explanations, and the treatment and management. So let's try and understand what anxiety and fear-related disorders are. So in order to understand these disorders, it's important to distinguish between anxiety and fear. Now, anxiety is apprehension or worry that you experience um, due to a perceived anticipated threat in the future, whereas fear is a response to a perceived imminent threat in the present. So the difference between fear and anxiety essentially is, think about the week before your CIE results are about to come. So I'm assuming you guys are in A2 and you just recently got your AS results a couple of months back. So the week before you guys got your results, it was obviously a very stressful and anxious time. You were worried about the result that you were going to get. You were not experiencing you hadn't gotten the result in that particular moment in time, but instead you were stressing out about something that is going to happen. So it's an anticipated threat in the future. You're worried about not doing well in your exams. That causes you high levels of anxiety. Fear, on the other hand, would be, let's say, if you have a phobia or a fear of spiders, and there is a spider that is physically in front of you, then you would be scared of it. Or let's say if you're afraid of snakes and the snake is physically in front of you, then there is an immediate threat to you. There is a danger that you perceive that is immediately in front of you in the present moment, and that is something that would obviously cause you fear, and it's a situation that you would want to definitely avoid. Now, let's take that same example, and if I tell someone that they're going to go to a zoo, and let's say they have a phobia of snakes, and I tell them that, tomorrow we're going to the zoo and we might even go to the snake enclosure. Now, even though they're not in that particular experience or they're not experiencing that event currently, just the thought of that is going to cause them high levels of anxiety. And when they're in that moment where the snake is in front of them, that would cause them fear. So fear is in the present, whereas anxiety is more about something that is yet to happen. So it says anxiety disorders are characterized by excessive fear and anxiety and related disturbances to behavior. Now, when you have excessive fear or anxiety towards a stimulus, you can experience many symptoms, including, um, you know, agitation, fear, high levels of stress, inability to concentrate or function normally. And your inability to function normally would obviously affect your social life, your family life, or even your professional life. Now, within the diagnostic criteria, we have different types of anxiety and fear-related disorders. Obviously, there are many, many more, but the syllabus covers three main types. The first one is generalized anxiety disorder. Now, a generalized anxiety disorder refers to a disorder where we have symptoms on majority of days for at least several months, where we experience high levels of anxiety. And this anxiety is caused by everyday events, such as, just feeling worried or apprehensive about something to do with your health, your family's health, your finances, work-related stress, studies, for example. So when one of these or many of these different events affect you and cause you high levels of anxiety over a prolonged period of time, couple of months, almost on a daily basis, then you probably are suffering from generalized anxiety disorder. That's why it's called generalized anxiety disorder, right? It's not being caused by anything specific. Okay, these are general everyday events that we experience. For some people, it can be extremely stressful. And when it lasts over a prolonged period of time, such as a couple of months, and it's causing you this anxiety on nearly a daily basis, you can end up developing anxiety disorder, generalized anxiety disorder. Other symptoms that accompany The anxiety would be muscle tension, sleep disturbance, difficulty concentration, and even at times irritability and frustration. Now, it's important to note that these symptoms should not be attributed to any other medical condition or due to medication or substance abuse. Because if you are taking some substances or medication, the side effects of which might result in high levels of anxiety, muscle tension, sleep disturbances, all these symptoms that we just discussed, then it wouldn't be classified as anxiety disorder because the symptoms are the result of something external. And when I say external, I mean, maybe another disorder or maybe, for example, side effects of medication. But if it's being caused by a particular event in your life that is causing you high levels of worry and stress, then it is most likely going to be generalized anxiety disorder. Now, because the name of the chapter is anxiety and fear-related disorders, we're not just focusing on anxiety, we also have to focus on the fear aspect. And phobias are basically something that we cover within this chapter because phobias fall under fear-related disorders. Phobias can cause you fear, phobias can lead to high levels of anxiety as well. Like the example I gave of someone who has a phobia of snakes. If I tell them that they're going to be in a situation where there are going to be snakes around them, just the thought of that would cause them high levels of anxiety. And if they're actually in that situation where the snake is in front of them, then it would cause them extreme fear. So it's important to discuss different types of phobias, and there are many types of phobias, by the way. One particular type of phobia that is part of our syllabus is agoraphobia. So this is characterized by excessive fear or anxiety in response to situations where escape might be difficult or help might not be available. So do not confuse this with claustrophobia, where you have a fear of small and closed spaces. This is more a fear of being in public spaces in large crowds where you kind of feel like you're stuck in these large crowds and escape might not be easily available. For example, using public transport, okay, or just being in a crowded area. So people who have this particular phobia would prefer staying at home and avoid, make a conscious decision to avoid being in such places where there are large crowds. So if they do find themselves in such a situation, it can cause them panic attacks as well as other embarrassing symptoms. They might start screaming, they might start crying. Obviously, it can be very difficult for them. So people will actively avoid these situations. And symptoms, in order for you to be diagnosed with agoraphobia, the symptoms must persist for several months and should be severe enough to result in significant distress and impairment to one or more important areas of your life. So take, for example, someone who's, working maybe at a place where there are a lot of people present. Like maybe you're working in event management where you're going to be around many people, so there is going to be a crowd. Or let's say just getting to work would require you to maybe use public transportation, like a bus or maybe the metro. So these are situations where there are going to be crowds, and people with agoraphobia would avoid them. So obviously it would affect your professional life, right? Maybe, your friends want to meet up, let's say at a concert. You wouldn't want to go there because you know that there's going to be a large crowd over there. So it will affect your social life, it will affect your personal life as well as your professional life. Now let's talk about specific phobias. Now, when we say specific phobias, this is when you have excessive fear or anxiety when exposed to a specific stimulus. For example, blood, for example, injections, or even injuries. So we tend to combine the three and we call it BII phobia, blood injection or injury phobia. This is when you have anxiety or fear when you're exposed to either one of these three stimuli. Now it says that the fear or anxiety will be disproportionate to the actual danger, and the person tries to avoid the phobic stimulus as much as they possibly can. If you know someone who has a phobia of needles and injections, during the COVID pandemic, when the vaccinations came out, you might have seen some people, avoiding getting the injections, avoiding getting the shot, the vaccination, because just the idea of being around a needle would cause them extreme distress. They might even start screaming and shouting. They might just run away from the situation. That's how extreme it is. Because it's important to understand that phobias are an extreme version of a fear. You might be afraid of something, but you still keep your emotions in check. You don't overly react in front of a stimulus if you're afraid of it. But when you have a phobia of something, then it's kind of difficult to control your reactions and your emotions. So it's an extreme version of a fear. So people with blood phobia, injection or injury phobias, the reason they would want to avoid needles, situations where there is blood, like going to the hospital, is because it makes them feel a little woozy, and it can obviously make them want to, feel a little, um, well, not want to feel, but they will feel like they want to faint because the blood pressure tends to drop. So it says the fear or anxiety will be disproportionate to the actual danger. Now, a needle obviously can be dangerous, but the needle is not like, a samurai sword or anything that it's going to chop you in half. But in the person's mind, they feel the danger or threat is far greater than the actual danger posed by the stimulus. So similarly, like getting maybe a blood sample, it just takes a couple of seconds. They just prick your skin and they just draw some blood. It doesn't really hurt much, and it's over within a couple of seconds. But a person with blood phobia would avoid that because in their mind, the danger or threat of being in that situation is far greater than the actual, negative experience that it is. And honestly, it's not that big an experience, not that negative an experience. It's just, a small moment where you experience maybe a slight pinch. But for the person who has a blood phobia, like I said, it's far worse than that. The actual experience, realistically is not, but in their mind, they make it seem like it is. So if you put them in that situation, they tend to panic. And as discussed for the previous types, symptoms must persist for several months, and they should result in significant distress or impairment to one or more areas of functioning. Like example, not getting basic vaccinations, not getting blood tests for maybe some illness that you may have and you may need to get tested. Okay. Or even just simply avoid going to the hospital. Now, there are a few ways in which we can measure different types of anxiety disorders. So the generalized anxiety disorder that we discussed earlier, that can be measured, or the severity of its symptoms can be measured through a questionnaire or a psychometric referred to as the Generalized Anxiety Disorder 7. And the reason it's called the GAD-7 is because it has 7 items. It originally had 13, but then the final version reduced it to 7. And it says over here that this is a questionnaire, which is a screening test often used to enable further referral to a psychiatrist. So it's not usually used to officially diagnose someone with generalized anxiety disorder, but it can be used to kind of set the foundation for someone who may need to be referred to a psychiatrist to be officially diagnosed with potentially having anxiety disorder. So like I said, it has 7 items, and the individual has to rate each item from a scale of 0 to 3 in terms of whether these experiences or these items or these situations apply to them within the past, I think it's 1 week, is it? Let me check. Past 2 weeks, yeah. So you have to rate from a scale of 0 to 3 whether each of the 7 items applied to you or did apply to you within the past 14 days. Okay. 0 being not at all, 3 being nearly every day. And these are the 7 items. Okay, let's just take a look at a couple of them. Feeling nervous, anxious, or on edge. So have you been feeling this over the past 2 weeks? From a scale of 0, which is never, to 3, which is nearly every day. Not being able to stop or control worrying too much about different things, etc. It's important that you know at least 2 of these items. Maybe you can use it if you're describing or evaluating this topic or the generalized anxiety disorder 7 in paper 3, or there's just a general question about it in paper 3. But there's a greater chance that you may be asked about these items in paper 4, because paper 4, which is research methods, tends to have a lot of questions about research methods because it is a research method paper. And the research method related questions tend to come a lot about these questionnaires and measures that are used in different chapters. Now, the scale I've taken from the textbook, but I would want to make a correction over here. It says 0 to 5 is mild anxiety. 0 to 5 is actually minimal to none. It's actually 0 to 4. 0 to 4 is minimal to none. Let me write that down over here for you guys. So 0 to 4 is minimal or barely any symptoms. 5 to 9 would indicate mild. 10 to 14 would indicate moderate. And then you've got your 15 to 21, which would indicate severe. So if you are getting a score for these 7 items within this range, 15 to 21, then there is a chance you might be suffering from severe generalized anxiety disorder. Like I said, initially it had 13 items, but then following research on 2,700 people from Missouri, the final 7 items were selected. There is another measure that we study in this section, which is the blood injection phobia inventory, the BIPI. Now, the previous measure was specific to generalized or measuring the symptoms and severity of generalized anxiety disorder. This one is more specific to blood injection injury phobia, which is why it's called the blood injection phobia inventory. Now, this questionnaire, this assessment has 18 items, which are actually situations, and the participant or the patient has to respond to each of these 18 situations in terms of 3 types of responses. So you need to evaluate your response for each situation in terms of cognitive responses, behavioral responses, and physiological responses, each on a 4-point scale from 0 to 3. 0 indicating never, 3 indicating always. And let me show you an example so you understand this further. Here is one example of the 18 situations in this questionnaire. It says situation, when I see blood on my arm or finger after pricking myself with a needle, you need to evaluate how you think you will respond if you are in this situation. And like I said, your responses are going to be cognitive responses, behavioral refer to how you think you will behave in this situation, how you think you will respond in this situation. Behavioral responses are your actual behavior that you will show in this situation. And physiological responses are how your body will biologically or physiologically react if you find yourself in this situation. Now, these aren't open-ended, so you don't describe how you think you will behave or how your body will react. Instead, for each of these cognitive, behavioral, and physiological responses, there are already some example items that are given in the questionnaire. You just need to rate each from a scale of 0 to 3, 0 being never, 3 being always. For example, when I see blood on my arm after pricking myself with a needle, cognitive response, I don't think I will be able to bear the situation, 0 to 3. I think I'm going to faint, 0 to 3. The key word over here is think, because this is a cognitive response. What do you think you will do in this situation? Behavioral response, what will your behavior be in the situation? Will you escape the situation immediately? 0 never, 3 always. Will your legs and hands start to shake? And lastly, what is your physiological response? How will your body respond if you are to be found in this situation? Will your heartbeat start to speed up? Will you actually faint? Again, rate from 0 to 3. So just like this, you have 17 other situations. You just need to rate them each on a cognitive, behavioral, and physiological basis from 0 to 3. And then you add your total score. And depending on how high the score is, it will determine your severity of blood injection and injury phobia. Now, although this is where this measure ends, there is an example study by Mas et al. In 2010 in Andalusia, Spain, in which we're assessing this BIPI questionnaire. Obviously, the GAD-7 and the BIPI, you should know the strengths and weaknesses of the psychometrics for a bit of paper 3 and mostly paper 4. So it's those standard strengths and weaknesses that we associate with questionnaires. So you can take a look at that. I've got a separate folder in my Google Drive for clinical psychology as well as health psychology for the evaluations or evaluative points for each of these chapters. So you can take a look at that if you want to just take a look at some possible strengths and weaknesses of these 2 assessments. Okay, now let's discuss this example study. So I'll try to explain the example study by giving a brief overview of what Mas is trying to test. He's basically testing 3 aims. Now, in order to understand these aims, it's important that I explain to you guys a specific type of validity. So we are familiar with the regular type of validity, which is internal validity or even face validity, which is basically the most basic form of validity that we use in our answers. When we say that confounding variables are controlled, therefore study has high validity. So that's basically face validity. Then we know about ecological validity as well, right? But there are many more types of validity. And maybe in one of the classes, I can, or in a separate video, I can just do, a little brief overview of the other types of validity that are essential to A2, not so much AS, but more A2. One of these is concurrent validity. So I'll write that down over here. Now, concurrent validity refers to how valid an assessment or a task is, that we can compare it to another similar assessment that is measuring the same thing, and it provides similar results. So what I just said might be a little confusing, so let me explain with an example. Let's say I've created a new IQ test, okay? Let's call it, I'll name it after my cat, Noob. So I've created the Noob IQ test. It's not the most appropriate name to give for an IQ test, but it's my IQ test, so I can choose the name. So I've created the Noob IQ test, and I tested out on a bunch of people. And let's say someone gets a score of 150, which would suggest that they are a genius. Now, I don't know if this 150 is a valid score or not, because this is a completely new IQ test. So who's to say that, these questions in the IQ test are even a valid measure of intelligence? So what I can do is I should check the concurrent validity of the Noob IQ test. And the way I can do that is I can compare these scores to, or I can compare this Noob IQ test to another IQ test that I know is proven to be validated, it's universally accepted. So something that I know is officially a valid IQ test. So if you guys remember from Baron Cohen, the IQ test that was used was the Wechsler Adult Intelligence Scale Revised IQ test. Now we know that that is a validated IQ test. Okay. So this individual who scored 150 in the Noob IQ test, I can ask them to take the WAIS IQ test. And if they end up getting a score within the same range, like let's say 148 or 152 or even 150, get the same score, then I know that they definitely have an IQ of this level. So that means the Noob IQ test is actually correct, and it is accurately able to assess your intelligence level. So my new IQ test, the Noob IQ test, I would say has concurrent validity, because I compared it to another similar assessment that is measuring the same behavior or emotion or whatever it is you want to call it, as my assessment. Okay, so this is measuring IQ, this is measuring IQ, both are producing similar results. So the Noob IQ test has concurrent validity. Now, why am I talking about concurrent validity? Because one of the aims of this example study by Maas is to test for the concurrent validity of the BIPI, okay, the blood injection phobia inventory, the one that we just discussed with the 18 items. This entire study is focused on the BIPI. Okay, so one of the aims is to see if the BIPI has concurrent validity, which means if someone who has blood phobia scores high in the BIPI for a phobia of blood, then how do we know that it's authentic? How do we know that the BIPI is actually correct when it says that this person has a severe or moderate or mild case of blood phobia? What we can do is we can make that same person take another validated assessment that is measuring blood phobia. And the one that is used in the study is the fear questionnaire. This was developed by Marks and Matthews in 1979. And this is a questionnaire that is measuring different types of phobias and fears, including blood injection injury phobia. So if you score high in the BIPI for a phobia of blood, and I want to test its concurrent validity, I will ask you to also take the FQ, the fear questionnaire. And if you end up showing from the fear questionnaire that you have a severe blood injection injury phobia, because you get a high score for blood injection injury phobia in the fear questionnaire, then it suggests that the BIPI has high concurrent validity. Okay, so if you score really high and you have severe blood phobia in the BIPI, you take the FQ, and that suggests that you have a severe phobia of blood phobia, then clearly my BIPI has concurrent validity. So that's one thing that they want to assess. The other thing that Maas wants to assess is Can the BIPI be used to distinguish between people who do and do not have blood phobia? So the study is being conducted on 39 people diagnosed with blood injection injury phobia, and they're being compared to a control group of 135 people, matched in terms of age, marital status, education, gender, and a few other variables. And they're all from Andalusia, Spain, with an average age of 24 years. The second aim that I was referring to is basically to see if I give the BIPI to all these 39 blood phobia participants and 135 control group participants, can the BIPI differentiate between the two in terms of blood phobia? So these 39 people who have the blood phobia should technically score higher in the BIPI, and the control group participants should not score as high. So that's the second aim. Can we distinguish between people who do and do not have blood phobia from the BIPI questionnaire? And the third and final aim of the study is to see if the BIPI is useful in assessing whether someone's symptoms of blood injection injury phobia are reducing or declining or decreasing after therapy or after treatment. So if someone has a very severe case of blood phobia, I will make them take the BIPI, and let's say it's giving me a very high score. Then they go for treatment. After treatment, the symptoms should subside, they should reduce. Will the BIPI be effective in showing me that their symptoms have reduced? So I give them the BIPI again post-treatment. If they are showing a lower score than the first time before treatment, then clearly the BIPI is an effective tool in showing how people's phobia of blood injection and injuries can, be measured and how it is being reduced post-treatment. So these are the three aims. Okay, number one, concurrent validity with the FQ. Number two, distinguishing between people who do and do not have blood phobia. And number three, is it useful in determining if someone's blood phobia symptoms are decreasing post-treatment? And long story short, all three aims were met. Okay, so that is the example study. Now let's move on to the explanations. There are three explanations. One is biological, specifically genetic, and two psychological. One will be the behavioral explanation and the other the psychodynamic explanation by Freud. We'll start with the biological explanation, which is the genetic explanation. The genetic explanation suggests that some phobias are genetic, innate, you're born with them. Now, from AS, specifically the Saavedra-Silverman study, the button phobia study, we learned that phobias are caused by classical conditioning, okay? Which means it's learned. But this biological or genetic explanation is saying that, not every phobia has to be learned. Some phobias can be genetic. You can be born with some phobias, especially if the phobic stimulus is something that poses a threat to your survival. So something like blood, we associate that with our survival. So it's possible that if someone in your family, like a parent or a sibling, has blood phobia, then you also might be born with one. And, I've actually tested this out informally. I've asked a few of my students who do have a blood phobia if anyone else in their family also has a blood phobia. And it turned out to be true. Majority people who do have a blood phobia have at least, sorry, one more family member who also has the same phobia as them. In fact, I think my uncle has blood phobia. And sorry, guys, just a bit of dust over here, which is irritating my throat. But I think my uncle has blood phobia. This was a long time ago. I think I recall an incident where I think he cut himself and he saw the blood and he fainted. And then his daughter rushed into the room to help him. She saw the blood and she also fainted. So both needed like immediate medical attention. Clearly, both of them had a blood phobia, father and daughter. So, that suggests that it is genetic. So let's see what it says. According to this explanation, we are born prepared to fear certain objects due to a threat posed by them to our survival. Therefore, we are genetically set up to avoid these objects. Okay, so anything that might, injuries, for example, needles because, they're pointy and blood is drawn from them. And, we want to avoid blood because just looking at blood makes us want to faint. So we look at an example study by Ost in 1992. It was done on 81 patients who have blood phobia and 59 other patients with a phobia of injections. So two different groups, I guess you could say, with one who has a phobia of blood, the other who has like a phobia of injections. There was a third group, which was kind of like a control group. Um, these are people who have other types of specific phobias like animal phobia, dental phobia, claustrophobia, so on. Now, the participants underwent a screening interview with a clinician, with a doctor, after which they filled out a questionnaire. And the whole purpose of this is just to get some sort of background about their phobia, history and nature about their phobia, what type of phobia they have, how severe is it, do they have any family members who also have the phobia, what is their reaction around blood injections, have they fainted previously in the presence of blood or injections, and so on. So we just want to get all this information through these interviews and questionnaires, okay, before beginning the main procedure. Um, Now, the main procedure, the task, the two different tasks, because one is being targeted, one is targeting the people who have the blood phobia, the other is specific to those with the injection phobia. So we'll start with those with the blood phobia. The blood phobia participants went through a behavioral test where they were shown a 30-minute silent but color video of a surgery being performed. So obviously blood would be informed, but blood would be involved. Okay, it's silent, but there is color. So they can, it's not black and white. So they can clearly see the redness of the blood during the surgery that is being performed. Now, what is the task that these guys have to perform? They were told not to close their eyes and to watch the video for as long as possible. Now, while they're watching, the experimenter is tracking their gaze direction, which means how long are they able to look at this video of the surgery being performed? Because the moment they look away or they take the remote and they switch it off, the trial would end. So we want to see how long they can go before they turn away or switch it off. Okay, the longer, the more your gaze direction. Okay. Um, those in the injection phobia group, they had to go through a different procedure, which involved 20 steps, obviously involving injections. The first step is a very simple step, starts by cleaning your fingertip. And the last one is actually performing a fingertip prick. You know, when they want to draw blood, then there's a little needle that just pricks your finger to get a little like sample of blood out. So they would have to actually do that. So 20 steps. And we want to, sorry, we want to assess their maximal performance, which is how long they watch the video for the blood phobia group and how many steps these guys are able to do before they are no longer okay with moving on to the next step for the injection phobia group. Now, along with that, the experimenters also rated the fainting behavior. So were the blood phobia or injection phobia participants showing any signs of fainting when exposed to their respective phobic stimuli? And the experimenters were observing and noting down any signs of fainting from 0 to 4, 0 being no fainting, 4 being fainting. And along with this, they also measured their heart rate and blood pressure, because when you're about to faint, your blood pressure tends to drop. So that would be a sign that you're about to faint. The participants also filled out a self-report where they themselves rated how much anxiety they were going through when performing each of these two tasks, from 0, which is not at all anxious, to 10, extremely anxious. So data is being collected from a bunch of sources, mostly close-ended and quantitative, but even qualitative data through the initial interviews that were conducted before these tests began during the screening phase. Participants also completed a questionnaire on their thoughts during the test. Like I said, their blood pressure and heart rate was monitored and tested as well. Now, the family history reports that were conducted or collected in the screening interview phase showed that 50% of the patients with blood phobia and 27% patients with injection phobia had at least one parent with the same fear as them, suggesting it is genetic. 21% of the blood phobics also said they had at least one sibling who shared the same phobia. So more signs that it's probably genetic. In terms of whether these guys have fainted previously in the presence of their respective phobic stimuli, 70% blood phobia patients and 56% of the injection phobia patients said that yes, they do have a history of fainting when exposed to injections or blood. These numbers were far higher than the control group, because remember, there's also control group. So the control group participants with other types of phobias, for them, it is more fear when they're exposed to like dogs or claustrophobia, tight spaces. Fainting, not so much. During these behavioral tasks, the mean number of fainting instances for the blood phobia group was 10.8. For the injection group, it was 7.7. So clearly, these people are likely to faint when they're exposed to their phobic stimuli. And Ost concluded that there appears to be a strong genetic link for these phobias. And these particular phobias, when people are in the presence of injections, blood, or injuries, are more likely to faint, as these stimuli are more likely to produce a stronger physiological response, such as fainting, compared to other types of phobias. Okay. Now let's get to the two psychological explanations. The first one is behavioral, which includes classical and operant conditioning. The main focus is on classical conditioning. This is, again, an AS concept, the button phobia study, but we'll revisit it looking at a study by Watson and Rayner done in 1920. This is a typo. It's not 192. It wasn't done like 2,000 years ago. It was done 100 years ago. 1920 by Watson and Rayner on a little boy named Albert, who was, I think, 9 months old. Let's understand what classical conditioning is first before we delve into this study by these guys. There is something called a neutral stimulus. Firstly, let's understand what a stimulus is. A stimulus is anything that leads to or causes a reaction or response. So if someone has a fear of something, like fear of snakes, then the snake is a stimulus, the fear is the response. A neutral stimulus is a stimulus to which you do not have any particular response or reaction just yet. So the initial classical conditioning, the original classical conditioning study was conducted by Ivan Pavlov, where he chose the neutral stimulus to be a bell, because his participant was a dog, and if you ring a bell in front of a dog, there is no real reaction as such. So it's a neutral stimulus as far as the dog is concerned. Then we have something called conditioning. Now, conditioning is learning through association. So if you do something again and again and again, your mind is being conditioned to learn a certain behavior. So a conditioned or unconditioned, rather, is something that is not learned. Something that is unlearned occurs more naturally. So when Ivan Pavlov put food in front of the dog's natural response was to start salivating, which is basically drooling because he's feeling hungry looking at the food. Now, a dog does not learn to salivate when it sees food. It's a natural response. It's a natural reaction. So I can say this is an unconditioned response. Okay, because it is a response, but it's not conditioned. No one taught the dog to salivate when it sees food. It's unconditioned, it's unlearned, it's natural. The thing causing the reaction or the response is food, so food would be the stimulus. But again, because this is all naturally happening, we'll say this is an unconditioned stimulus. But what's interesting over here about this experiment is that Pavlov starts to associate the bell with the food. Neutral stimulus is being connected with the unconditioned stimulus. How does he do that? Before presenting the food, he will now start to ring a bell. He rings the bell, he presents the food, the dog starts to salivate. He does this multiple times up until a point is reached where the dog, in the dog's mind, starts to associate the bell with the food. So an association is being created between the bell and the food. This is where the learning is happening. This is where classical conditioning is taking place. One day what happened was the researcher rang the bell, and even before presenting the food, just by listening to the sound of the bell, the dog started to salivate. So the dog associated the bell with the food. So by listening to the bell, he started to salivate. He learned that the bell means I'm going to get food. So now his reaction to the bell is to salivate. So the bell is no longer a neutral stimulus. It's actually causing a response, but a learned one. So we'll say it's a conditioned stimulus, and it leads to the response of salivating, which is obviously learned. So this is a learnt response to the bell ringing. So the previously neutral stimulus of a bell is now a conditioned stimulus, leading to a conditioned response of salivating. This is classical conditioning. How is this linked to phobias and anxiety? Because the same concept can explain how people learn phobias. And Watson and Rayner will explain that. So they did a study on a 9-month-old healthy infant named Albert, who apparently had no fear towards white rats or other similar animals. So they're going to try and create a phobia and make the kid learn a phobia of white rats. Very unethical study, by the way. Before the conditioning began, Albert was shown a range of different stimuli, such as a white rat, a rabbit, a dog, a monkey, masks with and without hair, cotton wool, burning newspapers, etc. So mostly like fluffy things. And there was no real reaction. Okay, the white rat was chosen in particular for the neutral stimulus. So they put a white rat in front of little Albert, no response, no reaction, neutral stimulus. This is where the classical conditioning is going to start. While presenting the white rat to Albert, they struck a metal bar that was behind Albert's head with a hammer. Please note, they're not smacking Albert's head with the hammer. Okay, please don't end up writing that. They just have a metal bar behind his head and they're smacking it with a hammer, creating a very loud noise. Now, any child will obviously get scared and cry to a loud noise. You make a loud noise in front of me, and I'll also get scared, and maybe I'll also cry. So, the loud noise is leading to the response of fear. This is natural. No one is teaching the kid to be afraid of a loud noise. Okay, it's natural. It's an unconditioned, it's an unconditioned response to an unconditioned stimulus. But what they start doing is, at this stage, the loud noise is the unconditioned stimulus, and the response of fear is an unconditioned response. This process was repeated multiple times 1 week after the initial trial until eventually one day, Albert just had to see. So, what they started doing is they would put the rat in front of Albert and then just repeat this procedure where they're making the loud noise and he's crying. One day, they put the rat, and Albert had already learned to associate the rat with the loud noise. They put the rat in front of him. By looking at the rat, Albert started crying. He became afraid of rats. And not just white rats, but any white fluffy object. So he developed a phobia of white rats through classical conditioning. Because the previously neutral stimulus of the white rat was now a conditioned stimulus leading to a conditioned response of fear. This is how classical conditioning suggests that phobias are learned. So while the previous topic by Ost was nature, because it's genetic, this is nurture. So you can maybe expect an evaluation on the biological or the genetic and the behavioral or the psychological explanation of what's this called? Anxiety and fear related disorders, including a discussion on, let's say, the nature versus nurture debate. With that, we come to the last one and perhaps the most interesting, if that's the right word, topic of the explanations, the psychodynamic theory by Mr. Freud. Sigmund Freud, who is a very famous character, um, very famous name in the field of psychology, often referred to as the father of psychology, he has some really strange theories. He talks about three components of our mind, of our personality: the id, the ego, and the superego. Let's understand what these three are first before we get into his psychodynamic theory and how he uses this theory to explain how phobias can develop. This is perhaps the most confusing part of this chapter, but also the one that grabs the students' attention the most. I just taught this today only in my school, and how there are always those kids who are just, not paying attention in their own world. Even they'll, switch on and lock in and just pay attention because of how weird this study can be. It's a case study. But let's understand the concept of the psychodynamic theory first. Now, he talks about three components that make up our personality. It's part of our subconscious mind: the id, ego, and the superego. The id he refers to as the instinctual part of our mind that contains sexual and aggressive drives and hidden memories. I like to think of this as the child within us. Okay, think of a young child who's who doesn't really think about consequences, or um, you know they don't really function on any ethical or moral standard as such. They just want their desires to be fulfilled. So maybe a child, couple of years old, doesn't really care about what's wrong and right. They just want, let's say, to play, or maybe they want a sweet or candy, and they want it now and immediately. And if you don't give it to them, it will cause them anxiety and frustration because you are repressing or denying their desires. So that's the id. Okay. So it's the instinctual part of their mind. And we also all have an id. Sometimes when you guys are studying, all of a sudden you just feel the need to kind of open up Instagram, scroll, you know, brain rot reels, which unfortunately I'm also guilty of. But yeah, we all have those moments where, there's just these strong desires that, the strong urges that we have that we at times cannot resist. But we also have something as adults, that is part of our subconscious mind, which we refer to as, or which Freud refers to as the superego, which is the ethical component of our personality. And it provides moral standards. It helps us. It's basically our moral compass. It's kind of like that part of our mind or personality that helps us distinguish between what is right and wrong. And using the same example, a student who's studying, all of a sudden, they want to like go out with their friends, watch TV, um, use their phone. So that's the id speaking. Okay? Very strong desire to do these behaviors. The superego, because you guys are adults, will come in and be like, you know what? No, we need to study because we have an exam, and we shouldn't waste time. Money has been spent on our education, so it would be wrong if we waste the time that we have right now, and maybe we should just study instead. So that's the superego trying to fulfill, the moral desires that you have within you. The id, on the other hand, doesn't want that. The id has its own instinctual desires, aggressive desires, impulsive desires. The ego is the most realistic part of our personality, and it's the one that mediates between the two. The ego is the one that kind of tries to resolve the conflict between the id and the superego. So, what will the ego part of our personality suggest? Let's study for an hour and a half, and then we can take a break, and then we can watch TV. So, fulfilling the desires of both. So we tend to function mostly on most days according to our ego, but sometimes the superego or the id gets the better of us. Okay, so this is the psychodynamic theory. Let's try to link it to the um, main topic, which is fear and anxiety. And along with this, it's also important to discuss something else that Freud talks about. He discusses different stages of psychosexual development. So these are the stages that we go through as children when growing up. The first is the oral stage. This is the stage where, young children, they take objects, they just put them in their mouth, they examine it with their mouth. After that, as you grow older and you're going through potty training, that is the anal stage of your psychosexual development. That is then followed by the phallic stage as you grow a little older, where you start to examine your sexual organs and your sexuality in a way. So you kind of are more aware of your own genitals and genitalia and so on. So the anal stage is going to be discussed, or is discussed, in the OCD chapter. um, the children who might develop phobias due to this psychodynamic theory, they are within that, or you could say maybe they're in the phallic stage of their psychosexual development. At least little Hans was, when the case study was being done on him, which is what we're going to be talking about now. So Freud talks about a case study on a 3-year-old kid at the time whose name was Little Hans. And his theory will be based around the psychodynamic theory to explain how this kid had a phobia of horses. Now, let me explain how his psychodynamic theory explains phobias. Okay, just give me 1 second. My iPad's battery is very low, so I'm just going to quickly grab the charger. Sorry for a short 10 to 15-second break. Okay, so continuing, let's explain how the psychodynamic theory can cause phobias. So basically, it begins with the id being denied or repressed. Now, the id, according to Freud, is the instinctual part and driven by sexual desires. So, according to Freud, even young children have certain sexual desires. And he talks about how a 3 to 5 year old kid who's part of his study, the case study that we're going to be discussing, has a strong sexual desire where he suffers from something called the Oedipus complex. Okay, it's written over here in bold. Now, the Oedipus complex, for those of you who are familiar with Greek mythology, you can kind of read up on it. It's quite interesting, Oedipus and Electra. The Oedipus complex, in psychological terms, is a case where a child, a boy, has a sexual attachment and attraction towards the parent of the opposite sex. Okay, a very strong attachment to the parent of the opposite sex. Whereas the Electra complex is when the girl has a strong attachment to the father, and in both cases, you grow envy and jealousy towards the parent of the same sex. So this would suggest that this boy, little Hans, is attracted to his mother, and he is jealous and envious of his father because he sees his father as competition. Okay, so yes, I know you're probably thinking, what is this? It's a very strange theory, but um, Freud kind of explains how because the desires of his id are that he wants to be with his mother, he was denied from this because his mother became pregnant with Hans's baby um, little sister. So she was obviously taken away from the house and hospital. So Hans was separated from the mother. So he wasn't able to spend time with the mother, who he was really attached to. So his desires to want to be with the mother were kind of being blocked and repressed. At the same time, he was also banished from his bed, from the parents' bedroom by the father. The father would not allow Hans to come onto the bed and spend time with the mother. So that caused him further frustration and anxiety because the desires of his id are being denied. He wants to be with the mother. The father is denying that. Okay, the pregnancy is denying that. So obviously, when the id is being denied, take any small kid whose desires are being denied, it will cause them anxiety, it will cause them frustration. So a lot of frustration, resentment to the father towards the father is building up within this 3 year old boy. Okay. Um, he was 3 years old when he met Freud the first time, but during the study, I think he's around 5. He was an Austrian boy suffering from a phobia of horses, like we discussed. He himself actually met Freud just twice. So most of this information is actually being provided by the father. So how correct or authentic is it? We don't know. Now, there's a lot more that's going to happen over here. When he was 3 years old, he developed an intense interest in his penis and he frequently played with himself, which obviously angered his mother because his behavior was deemed inappropriate. And the mother, in an attempt to kind of get him to stop, rather than being a responsible mother and telling him, you know what, this is wrong, this is inappropriate, you shouldn't do this, blah, 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 she took a whole new approach to it and decided a whole different approach to it and decided to threaten him and say, you know, if you don't stop playing with yourself, I'm going to cut it off. So she threatened to castrate him. If you tell this to a 3 year old kid, it's going to cause a lot of fear and trauma to him, which is what happened with poor little Hans. He developed a fear of castration. He got constantly worried that my mom is going to castrate me. He's already got a lot of anxiety that is building up because Actually, no, that anxiety part comes later. It's important to know that initially, fear is being built within him, fear of castration. Okay, so that's causing him a little bit of anxiety. So later on, the mother becomes pregnant, she's in hospital, she's away from Hans, who at this time has a very strong attachment to the mother. Now that the mother is away from him, that's also causing him anxiety. So he's got anxiety by fear of castration. Anxiety is now increasing further because he cannot spend time with his mother. And later on, there was an occasion where his father actually banished him from the bed. So again, he's not allowed to be with the mother. So anxiety is increasing. Now, before that happened, during the time where the mother was pregnant and away from Hans, and there's a lot of anxiety within him, he unfortunately witnessed a scene where he saw a horse fall down on the street and die. Now, for a young child who's like 3 to 4 years old, that's a very traumatic experience to see. You know, if you see a horse die, then it's something that kind of sticks with you as a child. You know, you don't really get over it that easily. You might have nightmares about it also. So Hans had a bit of anxiety building up in him already. This traumatic incident that he witnessed did not help him. Now, a young child's mind doesn't work very rationally, right? Because it's still developing. This kid, the anxiety and phobia and fear that he's developing of castration, not phobia, but fear and anxiety that's being caused by so many things, he ended up transferring it onto a horse. This is where the psychodynamic theory comes into play. Because in the psychodynamic theory, in terms of its explanation of a phobia, you have anxiety that is being caused by repression of the id, but you transfer it onto some other object. His anxiety was caused by repression of the id because he's being separated from his mother and because of the fear of castration. He ends up transferring this anxiety onto horses after this traumatic experience. And it's not something he chose, it's deterministic. It's not within his choice to do this. Okay, everyone goes through psychosexual stages of development according to Freud, it's biological. Unfortunately for him, when he was going through it, it had a few issues, and his mind decided to transfer this anxiety that's being built up in him onto horses, and that developed into a phobia of horses. Now, later on, his father actually denied him the chance to get into his parents' bed in the mornings to sit with his mother. That ended up creating resentment within Hans towards his father. And his anxiety started to increase. And that started being transferred more onto horses. So his phobia of horses grew. Now, Freud has a theory here that in reality, he's not actually afraid of horses. Horses are just symbolic of his father. And in reality, Hans has a phobia of his dad. And the horses are just symbolic of the dad. Because the real person causing him the anxiety is the dad. Because he's the one denying him the chance to be with the mother. The dad is denying his or repressing his id's desires. The dad is the one towards whom he has resentment. So the horse is just representing the dad. And he goes on to say that Hans had dreams of white horses with a black noseband, the black noseband representing Hans's dad's black mustache. However, his phobia did lessen by the age of 5. During this time, the father reported 2 very weird fantasies that Hans would have. One was that he had several children of his own with his mother, and that his father was actually his grandfather. Another really weird fantasy that Hans apparently was having, according to his dad, which he was reporting to Freud, was that he fantasized that a plumber would come, remove his penis, and replace it with a new, larger one. 5-year-old kid, by the way. So, is this true? Is this authentic? The father is saying it. We don't know. A lot of weird theories that Hans never existed, and Freud is actually Hans and just representing his own personal problems, and in the form of this case study. We don't know what is true, what isn't, because it's purely a case study based on qualitative data. So validity can be a bit of a problem, but this is basically his theory of how the psychodynamic explanation can cause a phobia. And a question came recently in an exam where this girl has a phobia of snakes. Describe how the psychodynamic explanation can explain why her phobia of snakes may have developed. Okay. And it also said something about that, something like her mother yells at her a lot or something. So in that, the answer was, maybe she is kind of has an attachment to the father, and the mother kind of denies that. I remember the marking scheme said that maybe she really wanted a penis and she was jealous of the fact that she didn't have a penis. And because she didn't have one and she wanted one, that was the repression of her id. The id's desire to want to have a penis was being denied, which caused her anxiety. She ended up transferring onto snakes because she saw a snake, so she developed a phobia of snakes. Um, which maybe represents her mother because the mother is yelling at her, so she's got resentment towards the mother. So the psychodynamic, basically the whole point of the psychodynamic theory is that when you have anxiety, because your id is being repressed, it's transferred on to something else. So that's basically what happened over here. Okay, let's get to the last part now. This is short, treatment and management. They're both psychological. We don't have any biological treatment. The first one is behavioral, which is systematic desensitization. This is very similar to the treatment used in the button phobia study in AS, where you are gradually exposing the person to the phobic stimulus while they practice relaxation exercises so that they become, so they unlearn, so they it's basically called counter conditioning. They unlearn the phobia that they have. Right? They use a concept called reciprocal inhibition, which means you cannot experience two contrasting emotions at the same time. So if I'm teaching you progressive, slow muscle relaxation, where your bodies and your mind is completely relaxed, you can't experience anxiety in such a situation. So if you are completely relaxed and I put a snake in front of you, or I show you a snake, which is something you're afraid of, it's impossible for you to feel anxiety and relaxation at the same time. The whole point of this technique is to kind of replace the anxiety with relaxation so that you can learn in your mind that I can be around snakes without having to feel scared. I can be relaxed around them. We don't start with throwing the snake in front of you immediately. It's a slow, gradual process. We start with something less scary. We create a hierarchy and we build up according to the hierarchy, and we move eventually to the phase or the stage which is the scariest for you, while practicing this muscle relaxation throughout. Eventually, you reach a point where you can be around the phobic stimulus and you're completely relaxed and you no longer feel anxiety. Let's see what it says. Systematic desensitization by Wolf is a way of reducing an undesirable response to a certain situation and helps to manage phobic reactions and responses. Okay. It is based on the principles of behavioral psychology that state that conditioning can cause phobias to be learned. So therefore, you can unlearn it as well. Counter conditioning. The process involves changing of one's frightening stimulus to a neutral one that causes no anxiety or fear. It's pretty much this concept of facing your fears until you are no longer afraid of it. This is based on the concept of reciprocal inhibition, which suggests that it is impossible for two strong and opposite emotions to occur simultaneously. For example, you cannot experience relaxation and anxiety at the same time. Therefore, the idea is to expose the individual to something that they have a phobia of, for example, spiders, which might cause them anxiety. Use systematic desensitization to help them feel deep relaxation and calm in order to unlearn their anxiety or fear towards the stimulus, like the spider. You begin by teaching them different relaxation techniques. They can choose whichever one they want. Visualization techniques, where they can imagine like a calm, peaceful scene. Progressive muscle relaxation, where you're teaching them slow breathing exercises, where they're focusing on their body, their muscles, relaxing it one by one, starting with the head, face, shoulders, chest, torso, all the way down to their toes, or even giving them an anti-anxiety drug, whatever one they choose, as long as they're relaxed. Then you create an anxiety hierarchy. Remember the fear hierarchy created by the kid in button phobia? Something like that. You list potential anxiety-inducing or provoking situations relating to the particular phobia, and you structure it in such a way that you start with the least severe or least distressing stage or situation, and you build up to the most distressing one. Finally, at each stage, the patient is assisted to remain calm. So as you go through each stage in the hierarchy, like in button phobia's case, if you were to use systematic desensitization on him, you would start with the buttons he has a lower phobia of, less distress with, ask him to be completely relaxed around them. Once he is okay, then move on to the phobia or the buttons that he has a phobic response of, let's say, maybe 4 out of 8. Practice relaxation until he is no longer worried around them or discussed it around them, and then move on to the one that he rated a 5 and 6 and so on. So finally, at each stage, the patient is assisted to remain calm and relaxed using their chosen technique while being exposed to the situation. And they do not have to move on to the next situation until they no longer report feeling anxiety in the current situation or the current stage that they're in. So until and unless you don't pass the stage that you're in right now, you don't move on to the next one. As the two emotions of calm and anxiety cannot occur simultaneously, the patient will unlearn their phobia and no longer feel anxiety in the presence of the stimulus. And with that, we can come to the last topic, the last study. This is the key study. It's at the very end. It's the second psychological, what do you call it, treatment and management of anxiety and fear related disorders. There is a bit of biology also involved over here. It's a key study by Chapman and Delap in which they're using CBT, which is obviously therapy, and a technique called applied tension to reduce the phobia or treat the phobia of blood injection and injury in a, I think, 42-year-old man who we will call T for confidentiality reasons. Okay. Now, applied tension is a very interesting technique which kind of helps people um, stops people from fainting if they have a phobia of blood. So if you're getting a blood test or you're around blood and you tend to faint, you can use applied tension to stop you from fainting. How does it work? There are 5 steps. The first thing is find a comfortable chair, obviously to sit on, not to smack your head with. So you find a comfortable chair and you sit on it. Then, as you are exposed to blood, maybe getting a blood test or maybe you're seeing blood, you start to tense the muscles of your arms, your torso, and your legs. Because when you see blood, what will happen is your blood pressure tends to drop. So by tightening and tensing your muscles, you're countering the drop in your blood pressure by actually increasing the blood pressure. So as the blood pressure drops when you're seeing the blood, by tensing the muscles, you're trying to bring it back up. You hold this tension for 10 to 15 seconds, and then you release for 20 to 30 seconds, and you repeat these steps 5 times while you're obviously exposed to blood, and that will help you learn that you can be around or injections without having to faint. Okay, so this is going to be used in a case study on this guy along with CBT. So a case study was conducted on an individual referred to as T, 42-year-old white male diagnosed with BII phobia. A lot of self-report used over here, a lot of assessments, a lot of questionnaires, interviews. You need to know the details and specifics of these questionnaires for paper 4, not as much for paper 3. Maybe they could ask you about some of these questionnaires in paper 3, but it's unlikely. But it can come. Through interviews, the researchers collected data about his life history. They've learned that he had many different challenging experiences in his life. Many family members passed away. He was living with a very anxious grandmother. He had also seen many of his family members faint during medical procedures. So along with interviews, there were many questionnaires that were used to assess his symptoms. So we assessed his anxiety through the Beck Anxiety Inventory. We wanted to see if he had depression through the BDI. We wanted to see how satisfied he was with the quality of his life through the QLESQ. We wanted to see how severe his phobia was and if he even met the criteria for blood phobia through the BISS, which is the Blood Injection Symptom Scale. And he did, by the way, he did meet the criteria for blood phobia according to this questionnaire. He was diagnosed with major depressive disorder based on an episode he had in college. Now, during the study, he went through 9 sessions of therapy as well as applied muscle tension. During CBT, he's just talked about how common phobias are. It's very common to have a phobia, how they develop, and so on. And if you can learn them, you can unlearn them. Now, just like in systematic desensitization, where you make a fear hierarchy and you work through it, he made a fear hierarchy with Chapman and Delap. And he would go through each stage where he would be exposed to different stimuli involving blood injection and injuries, and he would be practicing his applied tension. Okay. He was then asked to complete the SUDS, so another scale. This is basically assessing your anxiety from a scale of 0 to 100. And I think his score was like 42, which is quite high for this scale. Now, before undergoing treatment, he self-assessed himself, and the results showed he had severe anxiety, minimal depressive symptoms, overall good health in most areas of his life. Eventually, after the therapy and the applied tension, his scores, which were initially 40 on the SUDS, fell to almost nothing. And he only needed minimal applied tension towards the end. At a 4, 10, and 12-month follow-up session, his anxiety levels had dropped significantly, and he said he no longer had any fear towards medical stimuli, and he never felt better. Now, for example, before CBT and applied tension, um, he would often pass out during such procedures, but he had minimal symptoms even at the 12-month follow-up following this. Here are just some results, like the BAI, the Beck Anxiety Inventory, 21 items that you rate from 0 to 3 that measures your anxiety. Before CBT and applied tension, before they did the study, he had a very high anxiety score of 41. After this, it fell to only 7, which is very low at a 12-month follow-up. Now, there was another questionnaire, the Fear Survey Schedule 2. I actually have a document which has the details of all of these specific questionnaires, which I think I should put up on my Google Drive. I'll create a separate folder for that. This is 51 situations involving blood injection injuries. You have to rate on the 7-point scale. Initially, he had a score of 6 out of 7 for blood, meaning he was terrified by blood. 5 for death, illness, death of a loved one, which is very much fear. So, fear towards needles as well. So very high, very strong fear towards blood and needles and injections. But at a 12-month follow-up, his score was very low. And lastly, the BISS, 17 items that are assessing sensations that you experience during situations involving blood and injections. Before the study, he answered yes to all 17 items. Like, do you feel uncomfortable around injections? Do you think you'll faint around needles and so on? But at a 12-month follow-up, only 4 of the 17 items he said that he did have a problem with. Feeling anxious, heart pounding, feeling nauseous, and sweating were the only things that he still kind of experienced at times. But overall, his condition improved significantly, and he no longer had a phobia of blood injection and injury, and he was no longer fainting in the presence of these stimuli. So I hope that this helped you guys with understanding this chapter. And with that, we conclude, I think, all 5 chapters for clinical from, at least on my channel. And stay tuned, hopefully more content coming soon. Hoping that, I'll get started on the health psychology videos very soon. So that should be next. So take care of yourself, guys, and hope to see you soon. So bye-bye.